This lesson is going to be a little bit more about the TIPS procedure. I want to start with this image here, which is a diagram of the inferior vena cava and the three hepatic veins that feed into the vena cava. So first here you have the right hepatic vein that goes into the vena cava, you have the middle hepatic vein, and then you have the left hepatic vein. So there's three major veins that feed into the vena cava. And during a TIPS procedure, the right hepatic vein is usually the vein of choice. And so this picture is demonstrating a venogram of the right hepatic vein. So as you can see, this is the catheter coming down from the internal jugular down the vena cava, and then it is the catheter is placed into the right hepatic vein, and then contrast is injected. And so this is demonstrating the right hepatic vein. So again, the internal jugular vein is the most common approach. However, it can be done from a femoral vein, but just not as common. Okay, now we need to talk about the portal vein. Now again, this diagram is reminding us what the portal vein is. All of the veins from all of the viscera in the abdomen, like the stomach, the spleen, the bowel, all of those veins feed and merge into the portal vein. And then that portal vein enters the liver, and then that blood is then metabolized by the liver. Now there's several approaches to do a portal vein venogram. First, there is the transhepatic approach, and that's similar to a transhepatic cholangiogram, meaning a catheter is just simply punctured from the skin into the liver, and that's what this picture is demonstrating. So there was a needle, just local anesthetic was applied to the right flank area, and then a needle was pushed in all the way in, and as the needle is being pushed in and pulled out, you're aspirating, looking for blood return. And so here they've done that, and then at that point, so that here they have punctured the portal vein, then they put a catheter on in, injected contrast here. And remember, this blood is going into the liver. So they've injected contrast and it's going back into the liver, filling the liver. There is the transjugular approach, but again, this is more like a TIPS procedure, so not a direct, not a, this would be, during a TIPS procedure, I guess. Then you can do the superior mesenteric artery or inferior mesenteric artery. But for those, you're injecting it into an artery, then that contrast has to go to the intestine, and then you have to wait for the portal venous phase. So you're injecting it, and then you just kind of have to wait for it for the portal vein to fill. Going back briefly, we need to talk about the hepatic venogram. Okay, in a normal liver, the portal vein will not fill when you're doing a hepatic venogram. But here's the thing, if you're doing a hepatic venogram, usually the portal vein is not normal, or the liver is not normal. So a lot of times when you do a hepatic venogram in a patient with portal hypertension, which again, that's usually the case, then the portal vein will fill. So again, there's, let's see, I guess there's four routes that you can, in order to access that portal vein and to visualize it. Like I said, some of them are a little bit indirect routes, but those are listed there then. Okay, let's revisit cirrhosis of the liver, which is scarring of the liver, or fibrosis. All of those words are used interchangeably. Fibrosis, scarring, cirrhosis, all of those. Most commonly in the United States caused by alcoholism, chronic viral hepatitis. That chronic inflammation causes that liver tissue to eventually turn into scar tissue, and then what's called non-alcoholic fatty liver disease, or non-alcoholic cirrhosis. So this scarring of the liver that happens over time eventually restricts blood from the portal vein to freely flow into the liver. So over time, this leads to high blood pressure of that portal system or portal hypertension. The definition of portal hypertension is when portal venous pressure is 10 millimeters greater than systemic venous pressure. So that's when you are officially diagnosed with portal hypertension, is when that portal pressure is 10 millimeters of mercury greater than systemic. Portal hypertension causes several things to happen. First of all, it causes collaterals to form. It causes the blood to flow retrograde. So it's portal blood is supposed to be flowing into the liver, but if a person has portal hypertension, it'll flow retrograde or hepatofugal flow. And it can cause varices, which are varicose veins or dilated tortuous veins. Again, all of those mean the same. And again, it's all because of that increased resistance and backward flow. There are other causes of portal hypertension, one of them being portal vein thrombosis, and there's others also, but those are just the most common. Okay, the normal portal vein is 8 centimeters in length and 10 to 12 millimeters in diameter. Of course, if there's portal hypertension, that diameter could be a lot larger. Okay, measuring portal vein, I have a typo there. Measuring portal vein pressure is important in the diagnosis and treatment of portal hypertension. So measuring that pressure can diagnose a patient with portal hypertension, and it can also help in the management of it. So the junction of the diaphragm with the right cardiac border gives us a good landmark under fluoroscopy. So an occlusion balloon catheter is positioned in the hepatic vein but not inflated, and so this would be, and then pressure is recorded, and so that would be the free hepatic venous pressure. The free hepatic vein waveform is triphasic or variable, meaning it's squiggly. So as you can see here, this would be the free hepatic venous pressure here, the one that's squiggly. And again, that's because it is influenced by the right atrial contractions. Then the occlusion balloon is inflated, and then that would be the wedged hepatic venous pressure. And so the wedged hepatic venous pressure is monophasic, meaning it's a flat line. So again, and what that is actually measuring the portal pressure when the balloon is inflated. So again, this is representing free hepatic vein pressure, and then when the balloon is inflated, that is representing the wedged pressure, which is ultimately measuring the portal vein pressure. Okay, so the hepatic vein pressure gradient, then, the formula is wedged venous pressure minus free hepatic venous pressure. The normal gradient is less than, excuse me, or equal to 5 millimeters of mercury. So what we're saying is, let's say that the free hepatic pressure is 5, because that would be your normal venous pressure, 5. If the wedged pressure is 10, then that would be considered okay. A gradient more than 5 is indicative of portal hypertension. So again, let's say the free hepatic pressure is 5, and let's say the wedged pressure is 10, then that would be okay, because that is within the 5 range. But if it's more than 5, so let's say, okay, so now let's say that the wedged pressure is like 15, then that person would be considered to have portal hypertension. So, and a gradient more than 12 is at risk of variceal hemorrhage. So again, your normal venous pressure would be about 5, and so if your portal pressure is about 10, that would be okay, but if your portal pressure is about 15, then that would be considered portal hypertension. Real quickly, the TIPS procedure, the indications or reasons for doing a TIPS procedure is The two most common are the bleeding varices, and so the theory is then it would take the it would reroute the blood, it wouldn't go to the varices anymore, and then they wouldn't bleed, and then also ascites. So the procedure, just really quickly in some steps here: obtain the jugular vein access, catheterize the right hepatic vein, perform the wedged hepatic venogram to visualize the portal vein, usually with CO2 gas. Then make, now, of course, before all of this, is when you would do your pressures also. But this is the actual TIPS procedure. Then make a puncture from the hepatic vein to the right branch of the portal vein. Then do a portal vein venogram. Perform balloon angioplasty through the parenchymal tract. Then deploy the stent graft. So the stent graft is here. I have a picture of it. It's nitinol-based PTFE. PTFE is the generic word. The proprietary word would be Teflon, but they can't use Teflon because there's other companies that make Teflon. So nitinol-based PTFE. It is 8 to 12 millimeters in diameter. The length of it varies. But the majority of the length of the stent is a covered stent, as you can see in this picture, but 2 centimeters of the stent is bare metal. So you can see here this is bare metal. The bare metal portion is placed in the portal vein, as you can see in the picture. And the covered portion is to be placed from the portal vein through the parenchyma to the IVC. There is a radiopaque marker that demonstrates where the covered and bare metal portion meet. So in about here-ish, there is a radiopaque marker that helps aid in positioning. And so all is left to talk about then are the complications. And of course, while you're using all of these instruments, there's always different complications. But one of the most common would be extracapsular liver puncture. So meaning a puncture that would puncture all the way through the liver, and then that would lead to bleeding in the intraperitoneal space.